Hi, my name is Guy Vakala, and I'm a research analyst at the Ontario HIV Treatment Network. Today, I'll be presenting research work entitled Syndemic Effects of Adverse Childhood Experiences, Depression, and Substance Use on Antiretroviral Non-Adherence among participants of the OHTAN core study. I want to thank organizers of the CAR conference for providing me this opportunity to present the work. I also want to acknowledge our co-authors, Abigail Krog, Adrian Bass, Trevor Hart, Barry Adam, and Sergio Rueda. In the past 2 years, I've been an employee of the Ontario HIV Treatment Network. I have no other conflict of interest to disclose. Just some background about the issue that we're addressing in this research work. Previous research has shown high prevalence of adverse childhood experiences, depression, and substance use among people living with HIV than in the general population. And previous research also have shown in people living with HIV, adverse childhood experiences, depression, and substance use are each associated with higher antiretroviral treatment non-adherence. However, not much is known about the syndemic effects of these three factors on ARV non-adherence. Therefore, the current study examines the additive effects of multiple syndemic factors on ARV non-adherence among people who are in HIV care. The OHTAN cohort study, or OCS, is an open cohort of people living with HIV and receiving care in Ontario. A person is eligible to be enrolled in the OCS if they have a positive HIV antibody test or laboratory evidence of HIV infection, they're 16 years or older, they're capable of providing informed consent, and if they're receiving care at one of the 13 clinics participating in the OCS study. Data are collected through chart extractions, annual interviews, and linkage with external administrative health databases. Measures. So we use the Adverse Childhood Experiences or ACE-10 scale to assess traumatic childhood experiences, including physical, emotional, and sexual abuses, physical and emotional neglect, household dysfunction, including divorce, substance use and violence, and presence of mental illness and incarceration in the family. We use the patient health questionnaire to assess depression, and this scale has 9 items. We assess substance use by asking a single question that asks participant, in the past 6 months, have you used any substances for non-medicinal reasons? And they were asked to indicate a yes or no. ARV non-adherence was assessed again with a single item that asks participants, have you missed any of your doses of antiretroviral medications over the past 4 days? And they were asked to indicate yes or no. Now, in terms of statistical analysis, first we created the ACE count variable by summing responses to the 10 questions in the ACE-10 scale, and we categorized the scores into 3 or more ACEs versus less than 3 ACEs. Then we created number of syndemic factors as the sum of 3 or more ACEs, depression, and substance use. We calculated prevalence of ARV non-adherence as the number of people who missed 1 or more doses in the past 4 days divided by the total number of people on ARV. We calculated frequencies and percentages and compared them using chi-square tests. We also fitted logistic regression models to estimate unadjusted and adjusted odds ratios and confidence intervals. Our current sample includes 2,026 people who were on antiretroviral treatment and completed the annual OCS questionnaire between 2015 and 2017. The median age of participants was 50 years, 82% were men, 2/3 indicated as white, 68% identified as GBLTQ, 2/3 were born in Canada, 70% had a post-secondary education, 61% had income less than $40,000 a year, 56% have a drug plan with full coverage, 25% has one or more major comorbidity, 17% reported using substance in the past 6 months, 70% reported at least one or more childhood experiences, and 14% had depression. Now, in this slide, we show the association between number of ACEs, depression, substance use, and prevalence of non-adherence. So people who had 3 or more ACEs versus people who had less than 3 ACEs, the prevalence of non-adherence was 12.3% versus 6.7%. Among people who had depression, prevalence of non-adherence was 16.1% versus 7.6% with people with no depression. Among people who reported substance use, prevalence of non-adherence was 14%, and then among people who did not report substance use, it was 7.8%. These differences are statistically significant, indicating association between number of ACEs, depression, substance use, and prevalence of non-ARV adherence. In this graph, as you can see, with increased number of syndemic factors, the prevalence of non-adherence increased from 6.5% among people with none of the 3 syndemic factors to 27.6% in people with all 3 syndemic factors in a linear fashion. And this table presents results from the unadjusted and adjusted logistic regression models. The unadjusted estimates are presented on the left side, and as you can see, with increased number of syndemic factors, the odds of ARV non-adherence increased in a linear fashion. After adjusting for age, gender, race, or ethnicity, education, income, drug insurance, and medical comorbidity, as you can see on the right hand, the odds of ARV non-adherence increased with an increasing number of syndemic factors. And particularly, people with 2 or 3 of the syndemic factors had significantly higher odds of ARV non-adherence compared to people who reported none of the 3 syndemic factors. To summarize the findings, our analysis showed that having 3 or more ACEs, depression, and substance use were associated with increased prevalence of ARV non-adherence. Further, people experiencing 2 or more of these syndemic factors have increased odds of non-adherence to ARV treatment than people who had none of these 3 syndemic factors. Interventions that address the negative effects of adverse childhood experiences, depression, and substance use may help improve adherence to antiretroviral treatment. Our study has some limitations. We use the ACE-10 scale that assesses the most common adverse childhood experiences that occur within the family dynamic only. We also used single items to assess ARV adherence and substance use. And in our analysis, we also assumed equal weights for the 3 syndemic factors, that is, having 3 or more adverse childhood experiences, depression, and substance use. Our study sample included people who were in HIV care, and findings may not be generalizable to those who are not receiving HIV care. We want to acknowledge the OCS study participants, interviewers, and data collectors, Public of Ontario, the Ontario Ministry of Health, the OCS study team, the OCS Governance Committee, the OCS Scientific Steering Committee, and the OCS staff for their contribution to the OCS core study and to this current work that we're presenting today. I thank you for your attention. If you have any questions, please feel free to contact me at the email address shown at the bottom of this slide, tbekalen@ohtn.on.ca. Thank you.